Let's review hemostasis disorders, which can be divided into inherited and acquired categories. Inherited disorders. Hemophilia A is due to a deficiency of factor VIII. It is sex-linked recessive and therefore occurs almost exclusively in men. A hallmark symptom is spontaneous bleeding into joints. Treatment is with commercial factor VIII concentrates. Hemophilia B is due to a deficiency of factor IX. It is also sex-linked recessive and therefore occurs almost exclusively in men. Clinically, it is identical to Hemophilia A in terms of inheritance and symptoms. Treatment is with factor IX concentrates. Hemophilia C results from a deficiency of factor XI. It follows an incomplete autosomal recessive inheritance pattern. Clinical severity varies widely. It is especially common among Ashkenazi Jews. It is also the only contact factor deficiency that is associated with bleeding. Von Willebrand disease arises from a primary defect in von Willebrand factor. Von Willebrand factor binds platelets through the glycoprotein 1b/5/9 receptor. A secondary deficiency of factor VIII is often found. It follows an autosomal dominant inheritance, meaning both men and women are equally affected. It presents as a platelet adhesion defect with an abnormal platelet function assay. Treatment is with cryoprecipitate or DDAVP, a drug that increases von Willebrand factor. Factor VIII concentrates do not contain von Willebrand factor and are not useful for therapy. Factor XIII. Deficiency is an autosomal recessive disorder. It is not detected by common coagulation tests. It causes significant bleeding problems and poor wound healing. It can be diagnosed with the 5-molar urea test. Acquired disorders. Inhibitors are usually IgG antibodies directed against a clotting factor or against phospholipids. Lupus anticoagulant is directed against phospholipids. It is found in about 5 to 10% of patients with lupus erythematosus, but can also appear in malignancies, infections, drug therapy, and other autoimmune disorders. Screening tests use low-concentration phospholipid reagents, such as the dilute Russell's Viper venom test. Confirmation can be made with platelet neutralization, where phospholipids neutralize the antibody and the test corrects. It can prolong the APTT, but paradoxically predisposes the patient to clotting. Factor VIII. Inhibitor is the most common specific inhibitor, though others exist. A PTT mixing studies are used to differentiate a true factor deficiency from the presence of an inhibitor. If correction occurs with normal plasma, the problem is a deficiency. If correction does not occur, an inhibitor is likely. Vitamin K deficiency causes functional deficiencies of factors 2, 7, 9, and 10. PIVKA molecules, which are proteins induced by vitamin K absence, are present but not functional. Vitamin K comes from both dietary sources and gut bacteria. Deficiency may be seen in cases of poor diet or during broad-spectrum antibiotic use. The same laboratory picture is observed in warfarin therapy. Depending on the severity or stage, deficiencies seen in liver disease occur in factors 1, 2, 5, 7, 9, and 10. Factor VII deficiency is usually the most pronounced. Disseminated intravascular coagulation, DIC, is often secondary to sepsis, obstetric complications, or severe viral infections such as Ebola. It causes thrombotic occlusion of the microcirculation. Red blood cell fragments appear due to mechanical destruction. There is consumption of platelets and factors 1, 5, and 8. High levels of fibrin degradation products and D-dimer are typically present. The bottom line. Inherited disorders include hemophilias, von Willebrand disease, and factor XIII deficiency. Acquired disorders include inhibitors, vitamin K deficiency, liver disease, and disseminated intravascular coagulation. Correct identification of the underlying cause is essential for proper treatment.